Submersion injuries. This is another protocol that we have had in the past. Um, we don't really use it a whole lot, but I think it's applicable to the time of the year it is right now. At the time of this recording, it's July, so the possibility of having a drowning is there. So it's important to know this protocol. So some key points. Obviously, you do not want to become the victim. If you become the victim, you cannot help your patient. Routine cervical spine immobilization may impede airway management and is not necessary unless the circumstances indicate that trauma is likely. Um, Aggressive pulmonary support is essential in these patients. If possible, rescue breathing should begin while the patient is in the water. I used to be a lifeguard, and they actually used to, or I'm sure they still do, they teach you how to give rescue breaths in the water. It's kind of cool. Ideally, um, not that any of us will ever actually be in the water with the patient because we've got the rescue squad, but ideally, to do that, you have some kind of flotation device under the patient's shoulder, and then you use one hand to make your seal, and then you give a rescue breath with just like a mask. So chest compressions in the water are going to be ineffective because there's nothing there to like solid for the patient to lay on. There's no need to clear the airway of water prior to rescue breathing. The Heimlich maneuver should be reserved for patients greater than 1 year of age with suspected airway occlusion by forward body. So EMTs on submersion injuries, um, you do your routine patient care stuff, your assessment, all that. Conscious patients with submersion injuries should be transported to the hospital. Follow specific resuscitation protocol, including AED if a cardiac arrest. Manage cervical spine if concerning for mechanism, i.e. they dove it into the shallow end of a pool, they were involved in an MVC and somehow drove into the water, something like that. If BVM ventilation is required, utilize a two-handed seal, a PEEP valve, and BVM through foam rather than the frequent suctioning. So bag through the foam. If these patients may foam at the mouth, so just bag through it. You don't have to suction them. Consider non-invasive positive pressure ventilation, i.e. CPAP or BiPAP for respiratory distress. Um, Obtain a specific history, so time in the water, how long they were submerged, get a temperature on them. If they're hypothermic, you know, warm them up. Uh, Advanced EMTs, again, routine patient care. You want to establish an IV/IO access, but do not delay transport for that. If they're hypotensive, then bolus 1 to 2 liters of the crystalloid um, to maintain a systolic blood pressure greater than 90. If the patient has rales or crackles on exam, it's likely due to aspiration as opposed to volume overload. I know we're all taught if they have rales or crackles when you examine them not to give more fluid, but in this instance it's a little different. They probably aspirated on whatever water they were in as opposed to their just fluid overloaded. Paramedics, if the patient is in cardiac arrest, follow your ACLS algorithm.